Hey everyone, and welcome. If you're a nursing student, you are in exactly the right place. We're about to do a deep dive into contraception, and I mean really master it, not just for your exams, but for when you're out there in clinical practice.
So here's our game plan. We're going to break this down into 6 key sections. We'll start with the basics, move through all the different methods, and then wrap up with a super high-yield review of exactly what you need to know.
Okay, so you've read the textbook chapter, right? But how do you take all that information and actually feel confident talking to a patient? Well, that's what this is all about. We're building that bridge from theory to practice, zeroing in on the must-know teaching points and the critical warnings. All right, let's dive in.
All right, Section 1, Core Concepts. Before we can even begin to talk about the different methods, we've got to lay the groundwork for family planning.
So what is contraception really? At its heart, it's all about giving our patients control over their reproductive health. It's any method, any device, any strategy that helps prevent pregnancy. And our job as nurses is to be the expert guide who helps them navigate all the options to find what's right for them. Now, let's talk about your role in all this, because it is absolutely crucial. You're not just a walking encyclopedia of birth control methods. Nope. You're an investigator assessing needs, preferences, even cultural beliefs. You're a teacher breaking down the pros, the cons, the risks, and you're a historian documenting everything. You are the one making sure that a patient's choice is informed and, more than anything, that it's safe.
Okay, to really get contraception, you first have to understand the fertility window. It's pretty simple, actually. There are 2 magic numbers you have to remember. The first one is 24 hours. That's it. That's the entire time an ovum, or egg, is viable after ovulation. Just 1 day. A super short, super specific window. And the second magic number? 72 hours. Or, about 3 days. That's how long sperm can hang around waiting for that egg. So when you put those 2 numbers together, the 24-hour egg and the 72-hour sperm, that's what creates the fertile window. That's the period of risk.
Okay, let's jump into our first category of methods, natural and barrier methods. The big theme here, high user involvement. These are the methods that really depend on the patient to be on top of their game, which means they require a ton of teaching and motivation from us. So first up is the calendar rhythm method. This one is all about math, and you're going to have to teach your patient how to do this exact calculation. So first, they have to track their cycles for at least 6 months. Then they take their shortest cycle and subtract 18. Then they take their longest cycle and subtract 11. See that window between those 2 numbers? That's the fertile window. That's when they have to either abstain or use a backup method. All right, let's talk condoms. With condoms, it's a classic trade-off. On the one hand, they are amazing for protecting against most STIs. Huge pro. But on the other hand, their effectiveness against pregnancy totally depends on using them perfectly every single time. And here's a huge NCLEX tip for you. For STI prevention, it has to be latex or polyurethane. Why? Because the natural membrane ones, the lambskin ones, they have tiny little pores that viruses can slip right through. So they do not prevent STIs. That's a key teaching point. Okay, listen up because this is a big one for your exams. Toxic shock syndrome, or TSS. Whenever you see a question about a diaphragm, a cervical cap, or a sponge, your brain should immediately think TSS risk. Here's the deal. These devices block the cervix, and if they're left in too long, bacteria, specifically Staph aureus, can have a party and release toxins. So what's your number 1 job? Teaching. You have to drill into them. Wash your hands, wash your hands, wash your hands, and get that device out within the recommended time, which is usually no more than 24 hours. Super, super important. All right, we've covered barriers. Now, let's switch gears and move into hormonal methods. This is a whole different ballgame. These methods work systemically, inside the body to prevent pregnancy. They're incredibly effective, but they also come with a whole new set of risks and teaching points we need to master. Okay, let's clear up something that confuses a lot of students. The difference between combined pills and progestin-only pills, or the mini pill. The key thing to remember is how they work. The combined pill has both estrogen and progestin, and its main job is to stop ovulation altogether.
No egg, no pregnancy. The progestin-only pill, on the other hand, mostly works by making the cervical mucus super thick, like a roadblock for sperm. This difference is critical. It's why we give the mini pill to breastfeeding moms, because estrogen can mess with milk supply, and to people who can't have estrogen, like someone with a history of blood clots.
Okay, everyone, pencils down. The ACH's acronym is non-negotiable. You have to burn this into your memory. Why? Because the estrogen in combined hormonal methods, we're talking the pill, the patch, the ring, can increase the risk of blood clots. It's a serious side effect, so you must teach every single patient these warning signs. A for abdominal pain, C for chest pain, H for horrible headaches, E for eye problems, and S for severe leg pain. Any of these could mean a DVT, a PE, a stroke, a life-threatening emergency.
Here's another classic NCLEX question for you. If they ask which contraceptive method can increase the risk for osteoporosis, the answer is always the injectable, Depo-Provera. It can cause a temporary loss of bone mineral density. So what do you teach? You got it. Make sure they're getting enough calcium and vitamin D. This is also why we usually limit its use to about 2 years. Oh, and another huge teaching point for Depo, fertility can take a while to come back. We're talking up to 18 months after that last shot. Okay, now for one of the most effective categories out there, intrauterine devices or IUDs. These are what we call LARC, long-acting reversible contraception. We're talking about tiny devices placed right in the uterus that are basically set it and forget it, and are some of the most reliable reversible methods we have.
So, there are two main flavors of IUDs, hormonal and copper. And knowing the difference is key for patient counseling. You have to ask, what's their priority? If a patient says, I have horrible, heavy periods, you might lean toward the hormonal IUD. The progestin in it thins the uterine lining and can make periods way lighter or even make them disappear. But if a patient says, I want 0 hormones in my body, then the copper IUD is their hero. It works by releasing copper ions that act like a spermicide. The trade-off? It can sometimes make periods heavier and more crampy.
Just like we have H's for hormonal methods, we have PAINs for IUDs. It's another must-know safety acronym. This one helps patients spot the signs of a serious complication, like an infection or the IUD perforating the uterus or even falling out. You'll teach them to check for their strings every month and to call immediately if they experience any of these symptoms. P is for period late, A for abdominal pain, I for infection signs, N for not feeling well, and S for string missing. PAINs.
Okay, moving on to our final category of methods, permanent sterilization. This is the big one. It's the most effective form of birth control, but it's for patients who are 100% sure they are done having children.
For male sterilization or vasectomy, there is one teaching point that is more important than anything else. Are you ready? It is not immediately effective. I'll say it again. It is not immediately effective. There are still sperm in the pipes, and they need to be cleared out. That can take up to 3 months. So they absolutely, positively have to use a backup method until they go back for a semen analysis and get the all clear. This is totally different from a tubal ligation in women, which is effective right away. All right, deep breath. We've covered a ton of ground. Now it's time to pull it all together in a rapid-fire, high-yield review. This is where we lock in those facts that are going to get you points on your exam. Let's do it. Okay, look at this table. Think of it like a lightning round. The NCLEX says irreversible. You say? Tubal ligation and vasectomy. Good. They say decreases bone density. You say? Depo-Provera. Yes. They say risk of toxic shock syndrome. You say? Diaphragm, cap, or sponge. Perfect. See how this works? Use this to build those instant connections in your brain.
Okay, here we are, the final countdown. If your brain is full and you can only remember a few things, make it these 5 points. Best for STIs? Condoms. Big warning for hormonal methods? H's. The shot. Think bone density and delayed fertility. IUDs? Think pains. And a vasectomy? It's not effective right away. Got it? These are your 5 golden tickets for the exam.
So, there you have it. You've got the knowledge now. You know the science, the risks, the benefits. But the next step,
The real challenge is taking all this information and using it with empathy, with compassion, to help your patients make their own informed choices. And that, my friends, is the real art of nursing.